You didn't do anything to deserve your breast cancer. You didn't do anything intentionally to bring on your breast cancer. You weren't bad. This isn't a punishment. It's not a punishment. But if you can frame it into opportunity, this is your opportunity to have the best health of your life.
Welcome to another episode. And we are so fortunate to have again for part 2, Dr. Jenn Simmons. Welcome.
Thank you. I'm so happy to be here.
All right. Well, let's get started. We had such a big discussion in our last episode all about cancer, breast cancer, what a woman feels like when she's going through that. And you brought us some wonderful tips as well. So I'll encourage everyone to go listen to part 1, and I'll have that link in the show notes. And I want to get started with our second part, which is all about mammograms and breast screenings. How do you think a woman in her perimenopausal years should be screening for breast cancer? Like maybe some of what are options? And then are there any differences for how a woman should screen if she's in her 60s and 70s?
Screening is a really important conversation that we need to have. I unfortunately think that we have confused screening with prevention. And I can't tell you how many times as a breast surgeon, I had a woman in my office who said to me, like, I don't understand how I got breast cancer. I do my mammograms every year, right? So we've muddied the waters. And unfortunately, we've muddied those waters very intentionally. So I do want to spend some time talking about mammogram and talking about the mammogram debate, talking about how I feel about mammogram, and know that this is more than just personal for me, because I have spent the last 2 years, maybe even more, reading all the data about mammography, because I don't come to my stance on mammography lightly at all. So the mammographic screening program, which started in the 1970s, started with the very best of intentions. It was honestly built on a very, very logical, reasonable assumption, which is that breast cancer growth is both linear and predictable, so that breast cancer starts small, grows to some critical size, at which point it's more likely to metastasize. And if we could find those cancers before they reach that critical size, we could save lives, save women from additional treatment, and save breasts, right? Very, very noble. And I agree with all of those principles. Only the foundational belief that they were built on is not true. Breast cancer growth is neither linear nor predictable. Now, there are cancers that is true for. Cervical cancer, it's true for. Cervical cancer follows a stepwise progression. Colon cancer, it's true for. Colon cancer follows a logical stepwise progression. This is not true in the breast. In the breast, you can have atypia that never goes on to become DCIS. You can have DCIS that never goes on to become invasive breast cancer. And you can have invasive breast cancers de novo, meaning that they just start off as invasive breast cancers. So the mammogram identifying a lesion that's small is not meaningful, because with breast cancer, it's all about biology. It's all about the behavior of that lesion. And there are very small lesions that don't have aggressive characteristics, and they may not even need treatment. And there are very small lesions that are very aggressive, and you will get fooled by the fact that you find them so early, and then these people go on to have very, very aggressive disease. And the fact that you found it small or intervened when it was small doesn't mean anything. And it so happens that most of the aggressive disease is completely unaffected by mammogram. And what I mean by that is they either present in the interval between mammograms, or they present on the mammogram, but as very advanced disease. So no matter how many mammograms we do every year, the exact same number of women die of breast cancer. So we are not impacting the bottom line. No matter how many mammograms we do every year, the same exact number of women present with aggressive disease. And so when we look at the large scale studies and the ones that were not done by industry, but instead done by either governmental agencies or independent collaborative agencies, So when we look at the Cochrane report, which is the world's largest independent research agency, when we look at the Cochrane collaboration and we look at, they used the Swedish trials. And so we're talking about 600,000 women, half of which were screened with mammogram, half of which underwent self-examination. They all have the same exact access to care, and they have the same kind of care. So the healthcare is universal and the same. And what they found is that the number of women that die of breast cancer in both groups is exactly the same. But when you look at the group that's screened with mammogram, there are 20 to 30% more breast cancers diagnosed. The same exact finding in the Canadian breast cancer screening study of 90,000 women. 45,000 get mammogram, 45,000 do not, and they just have self-breast examination. And the same exact number of women in each group die of breast cancer. And the only difference is that we are diagnosing 20 to 30% more women with breast cancer when we screen with mammogram. So we're not saving lives, and we are causing more women to be treated for breast cancer. Now, if treatment for breast cancer were a benign process, it would be one thing. But the treatments for breast cancer have tremendous, tremendous ramifications for that woman's health in her future. And treatment for breast cancer decreases the duration and the quality of that woman's life. Because treatment for breast cancer, besides the surgical scars and deformity and the psychological implications that go along with that, they also accelerate heart disease, which incidentally is the number one threat to a woman's life exponentially after the age of 30. Heart disease is the number one threat to a woman's life. And we take that woman with breast cancer and we 2 to 3 times her likelihood of dying of heart disease. So we're actually giving her a worse disease than the breast cancer. And so it accelerates heart disease. It accelerates brain disease. It accelerates dementia, Alzheimer's, brain fog, anxiety, depression, sleep disruption. All of this is happening as a result of the treatment. It accelerates bone loss. And lest we forget, the same exact number of women die as a complication of a fracture every year as do of breast cancer. We can't give these women worse diagnoses than the ones that they walk in the door with, especially when we think about that 20 to 30%. So let me put that in a little perspective. We have 4 million women in the US living with breast cancer. If 20 to 30% of them are overdiagnosed, given a diagnosis of breast cancer because of a finding on mammogram rather than clinical disease, we are talking about 800,000 to 1.2 million women in the United States treated unnecessarily for breast cancer. These are scary statistics, and they're happening. They're happening every day because we are using a very unsophisticated tool to diagnose breast cancer, and we are making decisions based on this very unsophisticated tool. Now, even if they didn't save lives, even if mammogram doesn't save lives, but it saved breasts, I think that that would be a worthwhile endeavor. If finding the tumors early led women to less treatment, meaning led them to opt for lumpectomy or cryoablation over mastectomy, that would be something. That would be a worthwhile endeavor. Because I'll tell you that a woman who has a mastectomy, a woman who has her breast removed for breast cancer, is never prepared for the ramifications of that decision. Those scars, those mastectomy scars, are so much deeper than what you see with your eye. And when a woman has a mastectomy, there will never come a day for the rest of her life where she won't remember that she had breast cancer. Even with a very well done reconstruction, if a woman undergoes mastectomy, there will never come a day for the rest of her life that she won't remember that she had breast cancer. Whereas if she had a lumpectomy, she keeps her breast, it looks like her breast, it feels like her breast. There will come a day when her breast cancer doesn't define her. And we never take that into consideration. And women are so scared when they get that diagnosis. There are no four worse words than you have breast cancer. There aren't. This is so damaging on so many levels, on every level. You don't know who you are. You don't trust your body. You don't trust your health. You lose your self-image. You lose your relationship. You lose your sexuality. You lose your identity. It is so hard. And unlike any other cancer, this is an external one. This is one that you can't hide. No one knows if someone has thyroid cancer or esophageal cancer or pancreatic cancer or colon cancer. But when you have breast cancer, it's an external organ. You can't hide it. I think that we are, as a profession, as a medical profession, we're doing a terrible job at preparing women for surgery for breast cancer. And so many women are opting for mastectomy out of fear. And the truth is that with mammogram, the mastectomy rate has not dropped. It has increased by 20%. And so we're not saving lives. We're not saving breasts. What are we doing? Well, first of all, at least to some extent, and the estimation is around 5,000 cases a year, but I don't know that we'll ever know or ever really measure it. But mammogram is radiation. We gave it a lovely name, mammogram, picture of the breast. But the bottom line is that it's a breast X-ray. And in every other arena that we talk about it, X-ray, radiation causes cancer. It's a known carcinogen. And yet we tell women that mammograms are safe. And so what do? They get one every year. Sometimes they get one twice a year, right? Well, radiation is additive. So at some point, you are actually going to be causing some of those cancers. Because when you radiate something over and over and over again, that's what happens. And it's a known carcinogen. So that is one of my major objections to using mammogram, but it's just not a sophisticated technology. I don't think we're honest about it. It will miss 40% of cancers in the population that needs it most, which is the dense breasted population. So it's not even a reliable tool. And when you have a screening study, it should meet certain criteria. First of all, it needs to be safe, right? We cannot be using a test that causes cancer to screen for cancer. It's unconscionable. It ought to be accurate. So if you have a normal study, that should mean that you don't have the disease. The false negative rate needs to be extremely, extremely low. But that's not true of mammogram. So people go and have a negative mammogram and they think they're good. They think they're safe. And then, of course, you hear these stories all the time. I had a normal mammogram and then 2 months later or 3 months later, I was diagnosed with breast cancer. Happens all the time because it's a terrible tool. It has long been past the time to abandon mammogram. We should not be using mammogram for screening. There is no benefit to doing it. And I can list over and over and over again the downsides. It leads to over-imaging because it's so unsophisticated that it doesn't know what it's seeing. It leads to over-biopsy, and 75% of the biopsies that are done in the United States are done for benign, non-cancerous findings. It leads to overdiagnosis, as we have seen repeatedly in study after study after study. And it leads to overtreatment. And overtreatment comes at way too high a price for these women. So what do I do for screening, right? Because clearly I don't use mammogram for screening. So the first thing I think is that everyone should be doing self-breast examination. I don't think anyone is ever going to know you better than you know yourself. Every single woman thinks her breasts are lumpy. There is no exception to this. Every single woman thinks her breasts are lumpy. What we need to do is own our lumps. We need to know what it feels like when it's normal so that we can know what it feels like when there's been a change. If you are premenopausal, that self-breast examination needs to be 1 week after your cycle starts. If you are postmenopausal, you just need to do it once a month. So the first of the month, or just get into the habit of doing it during a time that you remember. And what a self-breast examination looks like is you want to look at yourself You want to look at yourself with your arms up over your head. You want to look at yourself with your arms by your side. You want to look at yourself with your arms on your hips and shift and look at the angles. And you're looking for dimpling. You're looking for an increase in size, a change in the shape of your breast, nipple inversion, anything that makes the appearance look different. And then you want to, if you're small breasted, you can do it standing up. If you're large breasted, you probably want to do it lying down and taking gravity out of it. And you just want to go radially around like a sunburst, go from outside to in radially around your breast using your fingertips and just pass your fingers over the tissue. And when you are encountering something, it's going to feel like a bump in the road. And if you find something, then this is the appropriate time to go have imaging. And you are almost certainly going to have conventional imaging. You're almost certainly going to have a mammogram, an ultrasound, an MRI maybe. But that is not screening. That is diagnostic. So I am not throwing the baby out with the bathwater. I know that those tools are necessary when they're necessary, but I don't think they should be used for screening. So self-breast examination. Then I use the ARIA test, which is available in the United States, but not available internationally yet. But I'm saying yet in that they are actively working on making this available to at least to Europe, Australia. They are working on this being available internationally. So what this test measures, it looks for two proteins that are abundant in the very early phases of breast cancer. So these are the S100A8 and S100A9 proteins. And as it turns out, they are found in abundance in your tears. So there's a tiny little litmus paper that you put in the corner of your eye, and you just close your eye for 5 minutes and allow your tears to soak on the paper, send it back, and then you get a risk stratification for whether or not you have breast cancer. So if you have a low risk, you don't have breast cancer and you don't need to worry about it. If you have an intermediate or high, you should be getting imaging. And even if the imaging is negative, which this will measure the very, very early stages of breast cancer. So you may not have something to show up on imaging, but you have the knowledge that you have inflammation in your breast. You have the precursor to breast cancer. And so you have the opportunity. You have the opportunity to find out where that inflammation is coming from. Take a long look at your life, how you're living it, and make those corrections so that you don't have to go on and get a diagnosis. But this test is very, very valuable. It has a 91% specificity, 91% sensitivity, which means that it's going to miss cancers in 9% of women. And this is because they have later cancers, because this is a very early marker. And the marker tends to go away as the cancer advances. So later cancers will probably not be positive on this. But these are the cancers that we should be picking up anyway with physical examination. It shouldn't get to that. So I use the ARIA test every year. It's ARIA, AURIA.care. And I have a special code to get people a 20% discount. It's Dr. Jenn 20 in caps, DRJENN 20. And you can get 20% off of that test. So the test is $138 with my 20% off discount. So it's very, very affordable. And this is very valuable information. And then the way that I'm screening the breast with imaging is using the QT scan. So in August, I opened up the first independent center using this technology called Perfection Imaging. And what this test is it's sound waves transmitted through a water bath that creates a true 3D reconstruction of the breast without pain, without compression, and without radiation. So this test was invented to replace the MRI because the MRI is very expensive. There are access issues. It's an uncomfortable test, and it requires gadolinium. And gadolinium is a heavy metal. And when you get gadolinium, it is stored in your body. It's stored in your organs, and it causes end organ damage. So MRIs are not a safe way of screening if you're using it with contrast. And if you're not using the MRI with contrast, it doesn't have the sensitivity. So this was actually invented to replace the MRI. And A woman essentially puts her breast in a warm water bath and takes a 10-minute nap. And then we do the other side. And in as little as 20 minutes, you have a true 3D reconstruction of the breast that has 40 times the resolution of MRI. But that's not even the most important part about this technology. So getting back to my objection with the mammogram is that the mammogram has no way of discerning what is important and what is not. And QT is the only functional technology. So it can actually measure the volume of lesions. And so if we see something, listen, if we see a cancer, we tell people to go be treated for cancer. We're not following these things. But if we see something that is questionable, that is ambiguous, we ask people to come back for a short interval study, and we re-image them, and we remeasure the volume. And so in as little as 60 days, we can have someone come back, restudy them, remeasure the volume, and measure a doubling time. And we know that cancers have a doubling time of less than 100 days, and things that are either not important or not cancer have a greater doubling time. And so we are able to save women from over-imaging, from overexposure to these dangerous elements, from over-biopsy, because that 75% that is getting a biopsy, we can instead follow them and determine if they even need a biopsy. And then we're saving women from overdiagnosis and overtreatment. So I have 2 centers in the United States. One is in the Philadelphia suburbs. One is in Novato, California. They are called Perfection Imaging, and Perfection is spelled with a QT in the middle. And then there are 5 other centers in the United States. There's one in El Dorado Hills. There's one in Irvine in the Center for New Medicine. There's one in Scottsdale, Arizona, in the Vincere Cancer Center. There's one in Crystal Lake in Illinois. And I'm putting an additional 10 up this year. I will, with alliance partners, put an additional 10, so there'll be 20 more in this year. And I plan to put up 50 over 5 years and 100 with alliance partners, because I want to make sure that everyone who wants access to this technology gets access to this technology so that we can safely, accurately, and painlessly screen for breast cancer. So that is what I use for screening. I understand that not everyone has access to QT, so let me talk about 2 other technologies. The ultrasound has been around forever. It can be used to screen for breast cancer. It will not find everything. With ultrasound, you cannot see calcifications, and this gets many people in an uproar, because how will we find DCIS, ductal carcinoma in situ, without being able to see calcifications? My argument is that I'm not sure we should be finding all of this ductal carcinoma in situ. Going back to where we started, breast cancer does not grow in a logical stepwise progression. And the vast majority of DCIS is not obligated and does not go on to become invasive cancer. So when we treat DCIS, we're taking something that is not life-threatening. No one ever dies of DCIS. No one ever dies of non-invasive disease. We're taking that, we're treating these women, and the treatments are compromising their health. So we're taking a disease that is 100% survivable, and by treating it, decreasing the likelihood of survival. So I think that we need to completely rethink, as a medical profession and program, what we're doing about DCIS, ductal carcinoma in situ, and how we're going to treat it, if we're going to treat it. Because what we're doing now, I think, is categorically wrong. We are treating it like it's breast cancer, and it's not. So because I don't think that DCIS should be treated like breast cancer, I actually have no objection to using ultrasound for screening. Now, most of the time, if you go to the imaging center, they will practically force you to have a mammogram before they'll do an ultrasound. What I have suggested to my people, what I have suggested to my community, is that you bring a waiver with you and you tell them that you absolve them from any blame for not finding the things that are found on mammogram. that you understand that ultrasound will not find everything and you're okay with that. And I think if you approach it like that, because they're really just trying to cover their ass. I mean, that's really what this is about, and probably generate a little more money for the imaging center. But let's just assume that they're just trying to cover themselves, and you're giving them an out. You're giving them permission and telling them that you're aware. You're aware that you're going to miss some things on ultrasound, and you're okay with that. And the other thing that I do like to talk about, because many women are using thermography to screen for breast cancer. And I don't object to thermography. I love thermography. I think it's an amazing technology, but it's not a screening tool for cancer. It's a screening tool for inflammation. Now, sometimes they go hand in hand, and I can argue that the cancers that don't ignite an inflammatory response probably don't need to be treated anyway. But thermography will not find all breast cancers. It does find inflammation. I think that's very important information. So I have my patients getting thermography every single year, but they're not getting thermography as a screening tool for breast cancer. They're getting thermography in order to know if they have inflammation, where they have inflammation, and I have them get whole body thermography so that we can address that inflammation, because the root cause of breast cancer in the vast majority of women is inflammation. And we need to know where that inflammation is coming from, and we need to address the inflammation. Whether you're diagnosed or not, you need to know where the inflammation is in your body, and you need to treat it. You need to acknowledge it.
Wow, I've got so many questions, and I'm practicing not interrupting, so that's why I haven't interrupted.
You're doing a great job, although it's feeling very monologue-y over here.
I know. I've got some comments to just keep my mouth shut and let the person talk, but we are practicing this now. So if anyone's listening, if you prefer the conversation and me interrupting, you let me know. But okay, so let's go back to the beginning. So what I'm hearing from you, and I've heard this, and I'm listening to your podcast and trying to digest this information. You are not against mammograms. That's the message people will see. They're going to see, if they see a short reel, that's the one that gets all the clicks and all that.
Yeah.
You're just saying, correct me if I'm wrong, that you look at it as not as a screening test, but as a diagnostic tool. After the fact, perhaps you do.
Yes.
It's not something that women who are generally healthy, have no family history, have no history of breast cancer themselves. You have a whole list of people who are just, they are not the prime candidates to go and get a diagnostic tool of mammogram. They can just get screenings in another form that you think is safe.
Yes.
Did I understand that?
So
correct?
Remember that screening is the healthy population who you do not have any reason to think that they have the disease. That's what the screening population is. So I cannot take someone who is healthy, who I have no reason to believe that they have breast cancer, and expose them to radiation. It's unethical. It's unethical. So I do not believe that anyone should be screening with mammogram, especially the high-risk population. Because the high-risk population, they are generally high risk. Like, let's take the BRCA mutation carriers. These are women who have a mutation in their gene code, that these genes are tumor suppressor genes. These are the genes that prevent you from getting breast cancer. And there's a certain population of people, somewhere around 5% of the breast cancer population, they will be born with a defect or a mutation in these genes that makes them more susceptible to getting breast cancer because their repair mechanisms aren't there. Their repair mechanisms are broken. If you take that population of women who can't repair their DNA and you expose them to a test that damages their DNA, you are virtually guaranteeing their breast cancer diagnosis. We should not be radiating the BRCA mutation carrier population. We cannot be radiating them for the purposes of screening. We're increasing their risk of getting the disease by exposing them to a modality that they cannot help. They cannot repair. They can't repair the damage. So we're actually going to cause breast cancers in that population if we screen them with mammogram. It's really unethical.
There's one thing I'm a little confused, and clear me in understanding. So you mentioned that there was no difference whether somebody got screened with mammograms and those who didn't screen in terms of deaths, overall deaths.
Right.
It doesn't matter if you screen or you don't screen. It's just the same people. If you got the cancer, you're going to die anyways. So, but then I'm hearing you say, well, wait, if you're taking mammograms, this is increasing your chances of getting breast cancer, because of the radiation risk. So wouldn't those studies that you quoted share some of that information where it shows, like, if you take mammograms, then we should have a higher rate of deaths?
No, because they're not causing fatal breast cancers. They are, some of them they're causing, right? Some of them are due to the mammogram, and others are just subclinical cancers, cancers that would have never presented themselves, because we're all making cancer cells in our body, all of us, all day, from the very young to the very old, everyone in between, we're making cancer cells in our body. However, we have repair mechanisms built into us. And so we can correct some of these mistakes. Our body can handle some of these cancers itself without any outside intervention. And this happens all the time. Or we have a cancer in us that's just not progressing. It's not growing. It's never going to be of clinical value. It's never going to become big enough to be a lump. It's never going to spread to the lymph node. It's never going to be life-threatening. But yet the mammogram can pick some of these up. And once you pick it up, these women are obligated to treat. But that it's 20 to 30% of the breast cancers that we diagnose that would have never become clinical disease. So it's confusing. It's confusing to people. And all I can tell you is we know this from autopsy studies, that there are a lot of women who die with a breast cancer, but not because of a breast cancer. Do you know what I'm saying? That the breast cancer never became a problem. But by screening with mammogram, we are identifying these cancers that would have never become a problem. Now, it's not all, and I want to be clear, I am not saying that breast cancer isn't a thing. I'm not saying that breast cancer isn't horrible. I'm not saying that people don't have breast cancer. Obviously, they do. Obviously, there is a proportion of women, a percentage of women that have breast cancer that need the treatment, that need all the treatment. They need everything. But 20 to 30% of the women that we're diagnosing don't need anything at all. They didn't even need to be diagnosed.
So how do they, because that's the question. If you're the 20 to 30%,
you have to use a sophisticated tool like QT. You have to use a tool that tells you what is growing, what is progressing, and what is not. You mentioned if someone has clinical disease, if they feel a lump, right? If they feel a lump, that should get treated. It's these microscopic cancers that probably would have never progressed to become disease that I object to treating. And I object to treating them because this is actually the topic of my next book. It's called The Forgotten Woman. When you treat a woman for breast cancer and you tell her afterwards that she should be grateful to be alive, and she is grateful, but when you treat a woman for breast cancer and as a result, she has brain fog, she can't sleep, she's anxious, she's depressed, she's gained weight, she feels unattractive, she's been mutilated, she has palpitations, she has heart disease, her bones ache, her joints ache, her muscles ache, she doesn't feel motivated to do anything, her relationship is suffering, sex is unwanted and painful, she has no libido, she's incontinent. It is hard to feel grateful when this is your life, because that doesn't feel like life. And we're doing a terrible job in survivorship with these women who are suffering in unimaginable ways because of how we treat breast cancer. And so if we're talking about 20 to 30% of women treated for breast cancer unnecessarily, and we're creating this reality for them, something is very, very wrong here. And unfortunately, a lot of it is by design and intentional. And I mean, I hate to go to this like conspiracy theory place, but the bottom line is that it's true. And we have written this narrative around hormones and around hormone replacement and talked about it being dangerous and not helping with brain health and bone health and heart health and causing breast cancer and leading to other cancers. And Instead, we'll just put you on an antidepressant and a sleeping med and a beta blocker and a lipid lowering medication. And we'll put you on NSAIDs for your pain and medicines for your incontinence. And we'll give you vaginal lubricants and we'll give you bisphosphonates for your bones. And I can name like 12 pharmaceuticals that people are put on for the purposes of undoing all this damage that comes as a result of breast cancer treatment. And these pharmaceuticals don't work, and they're not getting anyone any better, and they're not giving them a life worth living. And this is the forgotten woman. And it's a tragedy. And we're causing it. And we're causing it unnecessarily.
Yeah.
In this population that has microscopic disease that would never have gone on to become clinical disease, we need to do better. We need to do better with everyone, right? We need to do better with everyone. And that's why I am a huge advocate for bioidentical hormone replacement in women after they've had breast cancer. And the data is there. The data is there to support the safety and the efficacy of bioidentical hormone replacement after a breast cancer diagnosis.
This is the diagnosis, because I know some women who have been diagnosed with breast cancer during their whole treatment, they are on their hormone replacement therapy. And very often doctors would just get them off, like just stop the estrogen, stop pumping yourself through that.
Yep.
And here you're saying is no, take your hormone therapy throughout the process. Is that correct?
No. What I'm saying is that every woman needs to be individually evaluated. Her risk factors for recurrence need to be minimized. You need to figure out the why. You need to work through the why. You need to treat the cancer. And after the cancer is treated, you need to restore that woman's health. And most of the time, that means giving her the opportunity to go on bioidentical hormone replacement, but it's not done singularly and it's not done in a vacuum, right? It's all the other things that go along with it. You have to dial in the nutrition. You have to dial in all the lifestyle factors, the sleep and the movement and the mindset. And you have to look at where the toxins are coming from. Are they the invisible stress toxins? Are they the literal toxins that are in our food or in our self-care products? Are they in the air? Are they in your water? You have to find the toxins. You have to get rid of the micro-infections. You have to look in the mouth and see what's happening there, because the mouth is often a culprit for and harvesting disease that is manifesting as breast cancer, as heart disease, as thyroid dysfunction. And so you have to do all the things and figure out where the inflammation is coming from. But breast cancer doesn't happen de novo. And again, I don't want to say this isn't about blame or shame. This isn't about what you did. You didn't do anything to deserve your breast cancer. You didn't do anything intentionally to bring on your breast cancer. You weren't bad. This isn't a punishment. It's not a punishment. But if you can frame it into opportunity, this is your opportunity to have the best health of your life.
I want to go back to the QT scan, and you mentioned about the doubling time. And the issue that I'm hearing as well is, yes, mammograms may pick up so many things, even MRIs are very sensitive. And so they're picking up stuff that just maybe will never turn into anything. And that's why maybe for a certain population, it's not such a good thing, because then you'd be treating something that would never grow in the first place. So when you're looking at doubling time in the QT scan, you find a woman, you say, oh, there's maybe something going on here, and you have her come in for a second one. How long until she comes in again? Because I'm wondering if that doubling time is so fast and she waited too long, well, then the disease has progressed so much, and perhaps it would be a missed opportunity if she waits for the second one.
60 days, 2 months. It's nothing. Nothing.
If you have a breast cancer diagnosis, you may feel like years, waiting 2 months.
I understand that, but that's because our medical culture has convinced women that breast cancer is an emergency.
Yes.
And that's the first thing I talk about in my book, that with rare exception, it's an emotional emergency for sure, but it is with rare exception a physical emergency. So let's talk about the times that it's a physical emergency, because if this is you, go get help now, right? So if you have something called inflammatory breast cancer, and by the grace of God, this is a very aggressive form of breast cancer, and it is also extremely rare, 1% to 2% of breast cancers are inflammatory. An inflammatory breast cancer is someone who had a normal breast and like what seems like 1 week later has a breast full of tumor. It's red, it's hot, it's swollen. It has something called peau d'orange, which is skin of the orange. So like dimpling and edema, fullness in the skin. This is already systemic. This needs chemotherapy and it needs chemotherapy right away. So if that applies to you, you're not waiting, you're not stopping, you're not passing go, you're not collecting $200. You are getting treatment. If you have breast cancer that has spread to the bones and it caused a fracture, spreading to the bones alone is not an emergency. But if it caused a fracture, these people are in a tremendous amount of pain. It is impossible to heal while you're in pain. It is impossible to heal while you're suffering. So if you have metastasis to the bone that caused a fracture, you need radiation. You need radiation and you need to heal that fracture. The third thing is if you have metastasis, if you have breast cancer that has spread to the brain, so metastasis to the brain is living in a fixed space. The skull is a fixed space. When you have metastasis to the brain, there's always going to be swelling associated with it. So it's going to increase the volume of the brain. Eventually, it will cut off the blood supply, and that is not survivable. So if you have brain mets, that's something that needs to be treated right now. Other than those three things, you have time. This is not an emergency. You have time to do all the things that you need to do. Take a breath, learn about your diagnosis, get several opinions. Don't commit to doing any treatment until you fully understand that treatment and you fully believe that treatment is right for you. I can't tell you how many women are bullied into a treatment and they start it or they get halfway and they are so regretful because they finally learned about it. They're so regretful that they engaged in that treatment. So take the time, learn about everything, build your team, make sure that you are surrounded by people and professionals who not only you respect, but they respect you. You want to know that you are being seen, that you are being heard. Your opinion matters. And I am not saying that. My friend Sachin Patel says that the patient is the doctor of the future. I think that is a little hard for people to hear because they don't want all of that responsibility, right? That feels like too much. But also, no one is going to know you better than you know yourself. No one is going to care about you more than you care about yourself. And we need to stop entrusting, giving over our health and the sovereignty over our health to people who are not nearly as invested as we are, right? Like your medical oncologist doesn't have the same goals that you do. Your goal is to get better. Your medical oncologist's goal is to give you chemotherapy. They are not the same. They're not anything like the same. And your medical oncologist isn't thinking about the you in 10 years. Your medical oncologist is thinking about the you in 6 months. And that's it. That's it. All they want to do is get you through treatment and get you through treatment safely without too many complications. So you have to remember that like your goals and your team's goals are not the same. They're never the same. And you need to be your own advocate. So building that team and having your caregivers respect your opinion is of the utmost importance. And if you are dismissed, if you're not allowed to ask questions, if you're not allowed to get answers, this is not someone who you should be working with. Because if they don't listen to you in the beginning, they're for sure not going to listen to you in the middle and at the end. Mm-hmm. So building your team is so important. And then taking great strides to build your health. The thing that every single person with a breast cancer diagnosis gets is a treatment plan. But the thing that every single person with a breast cancer diagnosis needs is a health plan. You need a health plan. You need to build your health. And the time that you need to start to build your health is today. You're not waiting until after treatment. You're not waiting until some obscure time in the future. You need to build your health today. And you can recover your health. I've made a career of this. I've made a life of this personally. You can recover your health, but you have to commit to doing it. to.
So I'm wondering if I'm confusing the ARIA test and the QT test. And I keep starting to keep going back to it because
No, it's okay.
I want to give women these options, right?
Yeah.
If they are maybe not a candidate or they're thinking, oh, maybe I shouldn't get a mammogram, but I'm very concerned about breast screening and I'm going to do the self-examination as well
Self-breast examination.
as the ARIA.
I do all three. So self-breast examination, the ARIA test is the TEERS test that's measuring those inflammatory proteins that are associated with the early stages of breast cancer. And even if you don't find something on imaging, I use that information in order to help people. If that test has a medium or high risk, you know that you have inflammation. You know that you have the precursors to breast cancer. And so this is the perfect opportunity, especially if you don't find anything on imaging, to really commit to working on your health, knowing that this is an opportunity to improve your health. This is an opportunity to take that deep dive, to take that long look and figure out what is causing inflammation. The QT scan is imaging. It is looking for that physical finding, looking for that mass in the breast. And you can have an ARIA score that's positive and not find anything in the breast. And that just means that the process is so early that you haven't manifested the clinical disease yet. Amazing, right? Amazing. This is your opportunity to prevent getting that diagnosis. If we find something on the QT scan, that means that you have a mass in your breast. You may not be able to feel it, but it means that you have a mass in your breast. If it is an obvious cancer, like if I see something that's greater than 1 centimeter on the QT scan that has the characteristics that are consistent with cancer, I'm not telling someone to come back in 60 days. I'm telling them to go get treated for breast cancer. This should be clinical disease. Maybe they can't feel it because they're just not familiar enough with the physical exam to be able to feel it. Maybe even their practitioner can't feel it. Their provider can't feel it. But if they have 1 centimeter of disease, that to me, that's 1 billion cells. It's enough to get treated. If they have something tiny that normally would have set off an alarm for additional views and an ultrasound and an MRI and a biopsy in that conventional system, but to me, I'm like, I don't think that's going to be anything. Let's bring them back in 60 days. Let's take another look at that 2 or 3 or 4 millimeter thing. And let's see if it's something that is progressing. If it's something that's progressing, by all means, I tell them, go get treated. Go get treated. This is in the earliest of stages. Go get treated.
But what if somebody is seeing a doctor and again, every country is different and the whole medical system is different. And I'm not familiar with how this works, despite my mother passing away with breast cancer, but she was only 57. I was only 23. So I don't even remember the whole process that she went through. So let's say they get the QT scan and then you say, you know what, go get treated. And then they go to the conventional medicine doctor and then they say, well, no, you got to take the mammogram and do the biopsy and do all these things.
Yes.
Can she, and you're saying, well, there's no point, just go get treated. How is a woman going to navigate and try to convince her doctor?
She's not. She's going to get a mammogram and an ultrasound and a biopsy. And at that point, we're not talking about screening. At that point, we're talking about using the tools that we have for diagnostic purposes. And I am not saying that you will never have another mammogram again. I'm saying you never need another screening mammogram ever again. No one needs a screening mammogram ever again. But a diagnostic mammogram, when you're using it to determine what this is and what it needs and how to treat it, yes, absolutely. Now, do I tell people to protect themselves against the radiation? Yes. I have them take 2,000 to 4,000 milligrams of liposomal vitamin C and 100 to 300 milligrams of melatonin 1 hour before their study, and then again for 3 days afterwards, because I want them to be able to effectively protect themselves against the damage from the radiation at the time. But then these are necessary studies, and this is not the screening population anymore. This is a diagnostic study. This is someone who I believe to have breast cancer. Let's prove it.
So, but wouldn't the QT scan be enough for a doctor to say, oh yes, this is definitely cancer. We don't need to even do the mammogram?
Yes, but
because we know what it is, or does it not does the QT scan say what kind of a cancer it is?
No.
Okay.
All it is it's a more sophisticated exam than, let's say, an MRI. But an MRI isn't diagnostic either. It tells you the extent of disease. So the only definitive diagnostic test that's going to tell you what the lesion is, what the tissue type is, what it's sensitive to, all of that, that only comes with a biopsy. So you can certainly do a biopsy based on the findings of a QT scan, but that's going to take a pretty sophisticated person. So I could do a biopsy based on the findings of a QT scan, because if it's palpable, if it's something that I can feel, then I can just biopsy it. If it's something where I know where it is based on the finding of the QT scan, but I can't feel it, I can just run an ultrasound over the breast and be able to see the lesion on ultrasound and biopsy it that way. The problem is that most radiologists don't know what a QT scan is, don't know how to read a QT scan because it takes specialty training, and they are very much stuck in their ways. They do what they know how to do, and they know how to do a mammogram, and they know how to do an ultrasound, and they know how to do an MRI. And so they just lean on familiarity. Also, not for nothing, but that is the standard of care. And that is the standard that they are held to. Now, will it always be the standard of care? No. I think without question, QT will forever change not only how we screen for breast cancer, it will forever change how we image, because in not too long, the whole body scanner will be out and there won't be MRIs anymore because we won't need them. You'll just go in the whole body scanner and get an image that has more resolution than an MRI in minutes. So what woman wouldn't put her newborn inside of this scanner to make sure that everything is okay when there's no radiation, no pain, doesn't require sedation? I mean, who wouldn't do that?
That's the QT scan, right? So you're talking about?
That's the QT scan. But that scanner is not out yet. The whole body scanner won't be out for a few years. Right now, the only thing that is FDA cleared and being used on the market is the breast scanner, the QT breast scanner.
Let's explain what FDA cleared means versus FDA approved.
So approval is for drugs and clearance is for devices. So this device has FDA clearance because you only approve drugs and clear devices.
Okay. All right. I thought it had something to do with going through some rigorous testing that it's not have an equivalent of, I don't know, something that's already there.
No.
I'm well confused.
It just has to do with devices versus drugs.
The QT scan then is something that most doctors will not understand because it's too new. I'm guessing there has to be probably a lot of other research or something to convince these doctors the conventional medicine to accept it.
That research is coming.
Okay.
There are several units at highly, highly respected academic centers right now as we speak. And I'm telling you, without being able to share the names and where the data is coming from, I'm telling you that this will, without question, forever change how we screen for breast cancer. And we are on the precipice now of greatness. And we are going to make a significant impact for these women because this will avoid unnecessary biopsies, of which we are doing 75% of biopsies that are done for non-cancerous findings, benign findings in the breast.
Yeah.
It's going to avoid unnecessary biopsies, and it's going to avoid overdiagnosis and overtreatment because those questionable lesions will get brought back for follow-up studies, and we will know that they're either not progressing or regressing. And in that instance, we don't need to do anything about them. Those people do not need a biopsy. They don't need to get diagnosed, and they for sure don't need to get treated. And again, if we're talking about 20 to 30%, and we're going to diagnose 275,000 women this year in the US with breast cancer, we're talking about like 50 to 80,000 women who are getting diagnosed with breast cancer who don't need to be diagnosed with breast cancer. This is a huge number.
So when do you think this would be standard of care, the QT scan?
5 years.
Okay, let's go back to that. The women who don't need to be treated for breast cancer. If you speak to any breast cancer survivor, at least the ones that I know, I don't know, this is your world, not mine, but just the very few that I know, they would say, thank God I got my mammogram. They would argue with you and me, I guess, and say, look, I am 100% convinced. And maybe we don't know if they're in the 20, 30% or not. I don't know, but they are very grateful for their mammograms.
I know. So they are buying it hook, line, and sinker. I mean, the mammogram campaign is probably one of the 2 or 3 best campaigns that have ever been. And the tobacco campaign was one of the top 3. I don't want to talk about the second campaign because it may prevent this from being seen on YouTube. And the mammographic campaign. And it's one of the top 3 deceptive campaigns that have been so highly effective. Women believe that they need their mammogram. Women believe that mammograms save lives. Women believe that in a population standpoint, and they believe it personally. And whenever I post about mammogram, my social media, my Instagram is filled with stories of mammogram saved my life, and how can you do this? And it's so irresponsible. And how are you even a doctor? And I get it. And I'm so happy that their life is saved. I'm so happy that they're alive. But the likelihood that mammograms saved their life is nearly 0. And when we look at population studies, for every 2,000 women that we screen, we may potentially save one woman's life, and we will cause 5 to 20 women to be treated unnecessarily for breast cancer. Those scales are not balanced, and we are causing far more harm than good that we're doing with that. And it is a beast. That mammographic screening program is a beast. It is creating an unimaginable amount of money for the system. It is the entree program to the breast cancer program, and breast cancer makes a lot of money. It is a very, very highly profitable industry that does not want to change. Right?
So, okay, to reiterate for people listening, because I'm sure there's some people here going, oh my God, how is she saying this? But you are not against breast mammograms. You're just against it as a screening tool.
I'm against it as a screening tool. Because it does not save lives. And no matter how many mammograms we do every year, the same exact number of women die of breast cancer. All we are doing is creating this population of extra disease. We are picking up cancers that would not have become disease, that would have never affected a woman. And we are causing some of these cancers. Some of these cancers are caused by screening a woman year after year after year with mammogram, because it's not like we just do a mammogram once. We don't. We do it every year from women from the age of 40 until they're 70, 80, 90. That's a lot of mammograms. And most women are not getting 1 mammogram a year, because when you look at the callback rate, depending on where you're imaged, can be up to 50%. So those women are getting 2 mammograms. Maybe after that second mammogram, they're getting called back for a third in 6 months. So, and this can go on for women for many years. So they can have 3 years where they have 2 mammograms a year.
And not to mention that they may not, as we age and we're getting older, we have issues. We're maybe getting a bone x-rays, right? Because you're somebody like me with osteoarthritis, or you have your teeth x-rayed, and you have all these other, or you travel, right? We have, when we take a flight across the Atlantic, it's under radiation.
But I want to be clear. That scattered radiation that you get on an airplane, or get when you go outside or in your house or near your microwave, although I don't think that anyone should have a microwave, but the scattered radiation that you get from background radiation and the coned down radiation that you get in the course of a mammogram are not the same thing. Let's stop equating them. That is a rationalization. What is a rationalization? It's rational lies. That's what that is. That is how the industry gets you to think that mammograms are safe. It's simply not true. A 3-year-old understands the difference between scattered radiation and focused radiation. They are not the same thing, and we need to stop equating them, because it's dangerous to do that. We are giving women a false sense of security with the mammogram. We are telling them that it's safe. It's not. We are telling them that a negative mammogram means something. It doesn't. And this is a very unsophisticated tool that we are using to make sophisticated decisions. It's irresponsible at best and unethical.
It makes me think, I mean, I have had mammograms since I was in my 30s because, of course, my mom died of breast cancer.
Me too. I come from a breast cancer family.
And then on top of it, x-rays for the bones, x-rays for my teeth, the amount of radiation. Yeah, this is really horrifying. So when you think about it's the accumulation over time and the localized effect is the argument that you're having here. And that's just something, well, now it is what it is. I mean, I didn't know any of this before. So, and it's no wonder every time I get a scan, whether it's for my teeth or my mammogram, it's like, why is everybody running out of the room? Why are there big danger symbols everywhere?
Thank you. They're so safe, right? They're so safe that there's danger signals everywhere, that the technician needs to wear something on her jacket every day to count the amount of radiation that she's exposed to.
Yeah.
Right?
But it's so safe, then we
so safe. So safe. Okay. So yeah. I do want to share with you, though, that we do come into contact with radiation, both scattered radiation and focused radiation that you were talking about for your bones, for your teeth, all of that. If you are getting a radiologic study, so that is an x-ray, that is a mammogram, that is a bone scan, that is a DEXA scan, that's any nuclear medicine scan, like a PET scan, a CAT scan, please pre-medicate with vitamin C, with liposomal vitamin C, 2,000 to 4,000 milligrams. Get as much in as you can. The worst thing that's going to happen to you is you're going to get diarrhea. That's what happens when we take too much vitamin C. Do the vitamin C, do the melatonin. Don't get alarmed by the dose. This is not a sleep dose. This is an anti-inflammatory dose. This is not going to put you to sleep. You're going to be just fine. If you're worried, have someone drive you to your study, but you're going to be fine. Or do an experiment the day before you have your imaging and just take that 100, 200, 300 milligrams of melatonin and see what happens to you. You're going to be fine, I promise. So that protects you. That gives you lots of antioxidants to combat the free radicals that are generated when we have a radiographic study done. But also, every single day, you can be taking chlorella. You can be taking spirulina. You can be doing grounding every day. Go outside, put your feet in the earth, and discharge some of that radiation. Do castor oil packs. Help your body to detoxify, to get rid of some of the toxins, because even if the radiation is there, the radiation added on top of the other toxins is synergistically more. So let's help the body. Let's get rid of some of the toxins. So the spirulina, the chlorella every single day, the castor oil pack over your liver to help your liver to detoxify, over your breast to help your breast to detoxify, over your thyroid to help your thyroid detoxify. I would love to give a plug to the Queen of Thrones. I don't know if you know her.
I've heard of her. Yeah, a lot of people talk about her. Yeah.
She is amazing. And she has different kind of castor oil packs for the different body parts. I think she's just queenofthrones.com. And I think that there are so many safe, inexpensive ways that we can protect ourselves from the environment, because breast cancer at the end of the day is an environmental disease and is a metabolic disease. And we need to be extremely mindful of our environment, of our metabolism, and of creating health. When you create health, disease goes away.
If you could figure out exactly how to create the health, like you said, intentionally, we don't try to create disease and we try everything, like me, everything, but there's probably something I'm missing, I didn't get, or parasites, who knows, whatever. So there's sometimes we chew everything we can. We just don't know. We don't know what we don't know. And
so that's when a trusted guide, a trusted advisor comes into play.
Yeah.
And for my part, I don't think you're supposed to figure out your story yourself. If you can, amazing, great. If all you do is read my book, The Smart Woman's Guide to Breast Cancer, and that gives you everything that you need, amazing. Maybe you need to join my group and learn more. Maybe you need to take my course. I have an amazing online course called the Breast Health Blueprint, which is like 8 weeks filled with everything that you need to create your health plan. Maybe you need more than that. Maybe you need to work with someone who does this one-on-one. I don't know. I don't know what you need, but I can tell you that if you have an ARIA test that is intermediate or high risk, if you have a breast cancer diagnosis, if you have a thyroid cancer diagnosis, if you have any cancer diagnosis, or if you are not feeling energetic, optimistic, wanting to take every single day on with joy and purpose, you have inflammation in your body. Figure out where it is, figure out where it's coming from, and do it because you are so worth it. Health is so worth it. And we all want to do the same thing. Our goal, all of our collective goal at the end of the day is the same. We want to live as long as possible and die young.
Yeah. One question about, because you mentioned it 2 times, the vitamin C and the melatonin hack. You said take it 1 hour before your exam, whatever that is.
Yes.
And then 3 days after or 3 hours after?
No, for the 3 days after. So if your exam is on a Monday, you're going to take the stuff 1 hour before your exam on Monday. And then I want you to take it again on Tuesday, Wednesday, and Thursday.
Got it. Okay. Interesting.
Just to give your body the boost it needs.
Before I met you online, I sent you some studies I found, and I'm sure other people will go and do the same thing that I did and go, well, what is this real? Is it really real? Are people really dying or not dying, but dying more or less? And so one of the research articles that I found showed that it suggests that the number of lives who are saved by doing the mammography, again, this was a 2010 study that I shared with you. And in the end, the result was between 2 and 2.5 lives are saved for every overdiagnosed case. Like there are some studies that say, look, we recognize, yes, that we can overdiagnose things. And there are some people who are in this camp, but they conclude this. And then you think, well, gosh, how am I supposed to interpret this? And you came back with an answer. So let's hear what you said.
Yeah. So I've reviewed all of those studies actually that you sent me. And I think what we need to remember at the end of the day is who is authoring those studies and what their motivation and what their goal is. So one of the studies that you sent me was written by Laszlo Tabar, who is arguably the father of mammography. This is the mountain that he is willing to die on, and he will do anything, say anything, and construe the data in a way that will always favor mammography. But when you actually look at the data that he's presenting, and quite frankly, anyone who advocates for mammogram presents the data like this. When you look at mammogram and we talk about survival, what they're quoting in survival is 5-year survival. 5 years. So first of all, I will argue that if you have a 40-year-old woman who is diagnosed with mammogram and she lives 5 years, is that really survival in a 45-year-old woman, right? So what mammogram has is something called lead time bias. So super confusing, but stay with me here. So you have a woman who's diagnosed with a 3-millimeter cancer by mammogram. Tiny, tiny, tiny cancer. She gets treated. Unfortunately, it's aggressive. She lives 8 years and then dies of her disease. She got past that 5 years, so she is considered a survivor. There's another woman who is diagnosed. She doesn't have a mammogram. She's diagnosed because her lesion is a centimeter and a half, right? Because her cancer was diagnosed a little later, she lives 4 years after her diagnosis and dies of her disease. She died of breast cancer. They both, in actuality, died of breast cancer, but the one who was diagnosed because her lesion was only 3 millimeters and lived 8 years but then died of her disease, she is statistically considered a survivor. Do you see what I'm saying?
Yeah, I see.
And so the data that you're getting is not true. And the only thing that matters is absolute survival. The only thing that matters is overall survival, not 5-year survival. 5-year survival is a meaningless statistic, and we need to abandon it.
How long is a meaningful survival, in your opinion?
20 years. I think that it's reasonable to say that if you don't die of that disease in 20 years, I think that that is considered survivorship.
Yeah.
The other thing that I want to say that does not get reported in the data, and this is another thing that really muddies the waters, is that if you diagnose a woman with breast cancer, treat her for breast cancer, and the treatment for breast cancer causes heart disease, which if you are treated for breast cancer, you are 2 to 3 times more likely to die of heart disease than if you're not treated for breast cancer. So we know that it accelerates heart disease and that a significant percentage of the population of women with breast cancer will actually die of heart disease. If that woman who gets treated for breast cancer but dies of heart disease, that death is not attributed to breast cancer, despite the fact that the treatment for breast cancer caused her heart disease. So
we know that for sure.
We know that for sure. That death is not being attributed to breast cancer. That death is being attributed to heart disease.
And do you have the studies? Was that one of the studies you shared with me that show that the treatment is increasing her blood pressure and increasing her cardiovascular risks and stuff like that?
So what it's actually doing, it's twofold. It is accelerating the blood vessel disease. So it's accelerating coronary artery disease. It's actually damaging the blood vessels that supply the heart. So it makes them more likely to have a heart attack. It also damages the muscle of the heart and causes something called a cardiomyopathy. So it's twofold in the heart damage. And I did not include the cardiac papers, but I can certainly send them to you. And
you sent me so much. I was, would HRT protect a woman? Like, imagine she has to go through this. Okay, you're not saying don't get treated. Again, you're not against people not getting treated.
Of course,
it's about protecting her later on. So
yes.
I'm gonna ask you: is it possible once she's treated, now that she's back on her hormone therapy or just started bioidentical hormone therapy, will she perhaps at least lower that risk at least to heart disease?
Absolutely, 100%. It will decrease her risk of heart disease and be cardioprotective and be protective of the brain and be protective of the bones and be protective of the genitourinary tract and be protective of your mood, of your libido, of your desire to live, of your purpose, of your joy, all of it.
Now, what do you think? Just every time I say the same thing, and I use the word protective a lot. And sometimes I'm wondering, if a woman is listening to this and says, great, I'm going to go on HRT and I'm going to use my bioidenticals, and now I don't have to worry about heart disease. I don't have to worry about breast cancer. Or I don't have to worry about bones. And I think I'm trying to reframe way of speaking, because I always say you can't out-hormone a bad diet and lifestyle, right? You still have to do the work.
Nothing is in a vacuum. You have to do the work.
I'm trying to use the word more, it lowers your risk of certain things. Because if I'm afraid that a woman who says it's protective, she's not going to do the rest of the work. Well, it feels like I will never get this.
This is where I think the provider comes in. And this is where the provider is so important, because as a provider, I'm not giving bioidentical hormones to someone who is not doing the work, right? Like, if you are eating a processed food diet, if you're leading a sedentary lifestyle, if you're still drinking alcohol, if you're smoking, if you're not making any attempt to manage your stress, if you're not drinking my Kool-Aid, my proverbial Kool-Aid, you're also not getting hormone replacement from me. Now, I know that there are people out there who will do anything to anyone, right? I just hope that as we continue to spread this message, and I'm fortunate in that in the breast cancer world, most people are so afraid to prescribe to these women who have had breast cancer that they're generally not getting it from most providers. So I am hopeful that at least in this population, the people that are doing it well, are doing it correctly, are making sure that all of those dietary and lifestyle pieces are in place in as much as you can, that these people are optimizing their weight, that they're prioritizing sleep and stress management, that they're detoxifying, that they have detoxification practices, that they're not constipated, because that is one major source of toxins that people need to be very cognizant of. and that they are being properly monitored. I mean, you're not getting hormone replacement from me unless you're getting your scans every year, unless you're seeing your gynecologist every year and having an examination, unless you're doing your blood work, unless you're doing the follow-up work and I'm monitoring your hormone levels so that I know that you're not over treated or undertreated. And so I think in the hands of a hormone literate provider that is doing it in a responsible, highly and well monitored way, this is very safe and very effective. But it's not being done in a vacuum, and there's no magic pill for anything.
Mm-hmm.
There's no magic anything.
I think
it all has to be done in the context.
We need a whole other podcast for this. I think I opened up a can of worms with HRT and breast cancer. I know people who definitely need to hear this conversation, but I think it's like a whole other hour, and we've already gone way past our time because this was a huge topic that we covered. So grateful for all the work that you're doing and that you're sharing the studies. And if anybody wants to look at the studies, I'll have them in the show notes to provide to you. Do your own work, do your own research. And just to recap, we are not against mammograms, or you are not against mammograms. It's about using it as a diagnostic tool, not as a screening tool. And we can, maybe you go through again, very quick bullet points. What should a woman do to screen for her breasts?
Self-breast examination, the ARIA.care test, which is the tears test, QT scan if you have access. If you don't have access, ultrasound, and offer to sign a waiver holding them not accountable for missing things that the mammogram would find. And then I think everyone should have thermography every year just to make sure that there isn't inflammation that they're missing and a missed opportunity to have your best health and live your best life. I do want to add in, if you have had dental work, if you have metal amalgams, figure out how to get them safely removed. If you've had root canals, that is a dead tooth sitting in your mouth that is almost certainly collecting bacteria at the root, which is in your jawbone. And this can be a huge source of inflammation for people. So have a cone beam 3D CT of your mouth and make sure that you don't have cavitations. Or if you've had wisdom tooth extraction, because they can be a huge source of infection and inflammation. So that's how I screen. The other thing that I think everyone should know is you should know your vitamin D level and make sure that your vitamin D level is between 60 to 100 nanograms per deciliter, and know what your white blood cell count is. It should be 5.5 or above.
Great. One thing we didn't talk about that maybe you should just briefly mention are women with dense breasts. And there's 50% of the population of women have dense breasts. And so, as I understand, mammograms, that always, I have dense breasts. It's always telling me, you got dense breasts.
Yeah.
And the mammograms are just not picking up certain things. It's like finding a snowflake in a snowstorm.
Yeah.
And this is maybe another thing where maybe QT scan and ultrasound can pick up things that a mammogram can't.
For sure. Absolutely. And that's what the QT scan was designed for. It was designed for the dense breasted.
Fabulous. Okay. We are going to have a part 3 on hormones and breast cancer. So thank you so much, Dr. Jenn. And I really appreciate all that you do. And I look forward to seeing you again.
Yeah, it was my pleasure. Thanks so much for having me.